So, dear colleagues, really, I wish you a frank welcome to today's EHRA webinar on CIED infection, which patients are at highest risk and how to prevent it. I am Dr. Jean-Claude Darrow from Marseille University Hospital Latimone in France. The aim of this webinar is to give you a better understanding of the factors potentially associated with CIED infection, and the preventive measures will be discussed. The cases will be presented by Dr. Mauro Biffi from Bologna, Italy, very well known, and also very well known Dr. Jay Wright from Liverpool, UK. At the end of this 60-minute live event, you will be able to better identify the situations at high risk of CIED infection and the outcomes of such an event, which is very important to keep in mind. And you will probably have a better knowledge of preventive measures and how to implement them in clinical practice. This session is highly interactive. We strongly encourage you to actively participate by sending your questions, your comments at any time during the webinar through the chat. And for the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentation. Anything you need to know, just ask, and we will provide tips and tricks for your daily clinical practice. And finally, and this is very important, this webinar is possible thanks to an educational grant from Medtronic. Now I will hand over Mauro Biffi for his presentation. Mauro, please.
Thank you so much, Jean-Claude. I'm honored to participate into this meeting with this well-known community. After seeing my disclosure, I will introduce you to the typical case of a patient who is admitted 4 months after having received an aortic prosthetic valve to the emergency room just because of shortness of breath, and is transferred to the respiratory intensive care unit where bronchitis is suspected, but indeed heart failure is also diagnosed. And you are called from the ICU unit just because the patient has frequent bradycardia and 2-to-1 AV block at a low heart rate has been recorded in the last 2 days as persistent. So once you make the assessment of this patient, you realize that by echocardiography, the ejection fraction is 35%. The patient has a history of paroxysmal AF, has a moderately depressed kidney function with a creatinine of 1.7, with GFR around 44 millimeter per minute. He's on warfarin because of prosthetic heart valve. His blood tests are going back to normal. The white blood cell count is normal. PCR is declining to normal, but has been on this 6 days course of ceftriaxone for the suspected bronchitis. For sure, you realize that the patient has complete heart block by the time you see him and has a left bundle branch block pattern. So it's a regular case for a pacemaker implantation because now it's needed as a class 1 indication. But I want the audience to realize that we have to minimize the exposure to infection for this patient. The steps we normally focus on is the choice of the device, the implantation strategy that we follow during the surgery, and the antibiotic prophylaxis that is given to a patient like this. So my first question to the audience is, just give me a hint of what are your ideas about the type of the device and the impact that it may have on the infection risk. Single chamber has lower infection as no different for patient outcome, when I mean mortality. Or you believe that there is no difference in infection rate between single dual chamber and CRT device. Or the audience thinks that CRT implant, in this case, would carry a higher infection risk due to increased complexity compared to simple devices.
And okay, so now people are voting.
While we wait for this exploratory investigation, I would recall some ideas that I gathered from more than 12 very well conducted studies, although retrospective, in clinical experience of pacemaker and defibrillator surgery. And they point out that there are factors related to the operator, where the operator experience, the personal one, is key to minimize the risk of infection. The center volume providing, let's say, more widespread comprehension of this type of surgery matters in reducing the risk of infection. But above all, there are characteristics of the procedure that may portend a higher infection risk, just like the procedure length and the complexity. That is, whether the procedure exceeds 2 hours or involves more than 2 leads. The procedure types, upgrades and replacement compared to first implantation, and the type of the device being inserted, that is, cardiac resynchronization devices, are more frequently associated to infection.
Mauro, I would like to give you the result of the voting. 60% of the persons who voted think that CRT implant carries a higher risk of infection due to its increased complexity, which is completely in line with what you were telling. But, I would say, because 24% are thinking that there is no difference in infection rates between single, dual, or CRT devices. So maybe you will discuss it during your presentation.
Thank you, Jean-Claude. I'm really happy that 1 out of 5 of us thinks that there's no difference between this type of procedure. Although the truth is that if you look at literature, CRT is associated to larger infection risk. So why is that? Indeed, in this patient, we agree that the CRTP is the best solution because he has systolic dysfunction and has had heart failure symptoms. Let me put forth a question to unfold this aspect that there is no difference between the type of the device. Do people believe that the complexity is simply a matter of time, longer procedure because we have to find a suitable coronary vein, or because the device is most commonly bulkier, a CRTD, or that the LV lead is more prone to dislodgement than any other lead? Or do people think that all of these 3 aspects matter? Or do people believe that, as 24% of us think it doesn't matter, that simply it is the patient clinical profile that is more severe and these patients are frailer than the others? So while we await for this voting, I would highlight that in a large US registry of something like 1,100,000 patients, of whom 45% were CRTDs, it happens that indeed CRTD have 1.7 increased risk of complication overall, not infection, overall complication. But once you look at this, you realize that CRTD have an early plateau in complication rate that is mostly related to lead procedures with or without pocket complication. Means that we are dealing in CRTDs with more lead-related complications instead of pocket complication. And that could hint that lead issues, frequently dislodgement or phrenic stimulation, are the leading cause of pocket reopening, which may be the true issue behind this finding.
The result is that nearly 80% of the persons who voted think that all the reasons you were thinking about are really implicated
into
the longer procedure, the bulkier device, and the LV lead, as you are pointing out now.
I'm happy that people think of this because they are probably right, but I would come up with in favor of the 24% that think that there's no real difference between a single, a dual chamber, or a 3-chamber device, just because in experienced hands, and I take the Danish study for instance as the typical portrait of experienced operators, in experienced hands, CRT, either P or D, doesn't make any difference when it comes to infection rate compared to no CRT. In this case, it is single chamber or dual chamber defibrillator. And matter of factly, in the paper, this was hardly mistaken because the control group had no CRT and had no ICD, but there were only 46 patients with devices that were pre-existing pacemakers or implanted pacemaker during the study. So when you correct this denominator, even pacemakers have a 4.3% infection rate that matches perfectly the other cohorts. Means single, dual chamber or CRT doesn't really make a matter of difference when it comes to the infection. And in Danish practice, this was held true also when you look at pacemaker. Here we have the down pace trial where we look at those patients who had an upgrade to a single chamber to a dual chamber pacemaker. The infection rate increased tenfold and increases 7.5 folds, and this was related to a common pocket opening to insert a new RV pacing lead, not a very sophisticated procedure. So I would say what the CRTD and this population have in common is a pocket reopening, in this case for an upgrade. So I would come to the conclusion that opening the pocket in elective procedures doubles the risk of infection, and this is the case of upgrades. But opening the pockets earlier, as in the US registry, for a lead dislodgement carries a 6-fold risk of infection. And if the procedure is very long because it is a difficult case, then the length of the procedure increases the risk something like tenfold. And if you sum up these two, it's a 15-fold increase of infection.
Yes, but Mauro, do you think it's only all about the procedure or also the patient? Because, CRT patients are not as the other ones.
I totally agree with your point, because we have been seeing along years that the clinical profile of CIED recipients is changing. They have more comorbidities, and the comorbidities are chronic illnesses that we have to deal with, just like renal disease, diabetes, and chronic respiratory disease. And matter of factly, reviewing the literature, we have understood that end-stage renal disease or moderate renal disease carry an increased risk that is just comparable to an early dislodgement. And also chronic diseases like respiratory disease or diabetes, they double to increase 3-fold the infection risk. So indeed, the patient profile is heavily impacting the infection risk. Now coming to our patient, we have decided that he needs a CRTP because we want to avoid a upgrading procedure in the event he would further deteriorate the ventricular function. He has anticoagulation therapy because he has a prosthetic heart valve, has been admitted to the hospital 7 days ago, and has received a course of IV antibiotics. So we need to devise a strategy for this patient to minimize the infection risk, although it's an ordinary case. And I would ask the audience whether they would focus from this point onward to have a very fast procedure, to have a procedure as fast as possible, but pointing to minimize bleeding complication, or if they would focus particularly for this patient on an antibiotic prophylaxis. Which do they think is the most important point?
So now they can vote, but in the meantime, you will
move forward, and we remember that there are indeed serious complications to be accounted for when you operate on a patient who is on dual antiplatelet, warfarin, or anticoagulant therapy plus an antiplatelet agent, which are rare but not completely uncommon. So what we have learned from the Bruce control study is that hematoma formation, clinically significant, just like those requiring prolonged hospitalization, pocket reopening, or stopping the anticoagulation treatment, occur at least 4-fold more frequently in those patients who stop warfarin and are bridged with heparin. Indeed, continuing warfarin treatment is safer because you can do it at reasonable therapeutic levels without an added risk of severe bleeding, at minor risk of severe bleeding. And this is particularly important when you think that a hematoma, defined as clinically significant, increases 7-fold the risk of infection. So we must be very careful for this patient who is on warfarin as to minimize this risk. Luckily today we have guidelines.
The answer, many people, 65%, they think that we should use an individualized antibiotic prophylaxis. 17% management of anticoagulation, which is key, as you told, and 18% a very fast implant procedure. So it's really a mix, but really the antibiotic prophylaxis tailored seems to be favored.
That is really interesting because it's something brand new for our practice, and we need to establish probably something better than what we had in the past.
This is about
just closing the anticoagulation issue is that today we have a position document from EHRA that can assist the decision making for any implant operator, and that nicely splits the population into a low thromboembolic risk patient that can safely withhold VKA and antagonist without having to face a serious thrombotic problem, and those who have a moderate increase in thromboembolic risk, who should undergo surgery with uninterrupted warfarin treatment, keeping the INR in the therapeutic level, I would say tailoring and titrating down, as the recommendation paper points out, to the mid to lower level, just to be safer from the bleeding side while maintaining a good antithrombotic prophylaxis. And in that sense, the CHADS or CHADVAS score may be really helpful. Same thing will be probably happening when we are addressing those patients who have received new oral anticoagulant drugs, where we can safely decide based on the hemorrhagic risk. What we shall remember is that hematoma needs to be prevented because it's more impacting the risk than the anticoagulation treatment itself. And what a hematoma has in common with a lead dislodgement in CRT or with upgrade procedure is that it dictates pocket reopening, which in this scoring system provided by SNIT-MITA is the highest risk factor in highlighting the infection rate after the procedure. So avoiding pocket opening is a mandatory strategy, whether we are looking about great and broad topics like device longevity maximization, prevention of lead dislodgement by decafixation, or electronic management of issues. This is the leading door to endocarditis. So, having addressed the anticoagulation point and going to the 50% and more of colleagues that thought about antibiotic prophylaxis, I would challenge the audience in this very difficult case, because indeed it's a normal one, but we are dealing with a patient who has been in the hospital for 6 days, has received a cephalosporin for 6 days, has a normalized white blood cell counts, the inflammation pattern is going towards normal, but we have to think what to do next for the surgery we are planning. Go on with the cephalosporin or add something else, for instance levoxyzine, or resort to what we have from guidelines for aiming at the prevention of surgical site infection, that would be cefazolin or vancomycin. I would like to have the opinion from the audience. While we go on, remembering that the pathogens we are addressing are 75% of the time staphylococci that may have different response to antibiotics, other gram-positive cocci, gram-negative bacilli, culture-negative infections, and sometimes polymicrobial infection. Once we address this patient, we have to think choice of the antibiotic shall be driven by the patient profile. And patient profile, we mean the coexisting morbidities, the possible sources of entry site of the bacteria, the type of procedure we are doing, an elective patient coming from home versus a patient who was already an inpatient admitted to the hospital, and whether this is an inpatient, whether it has been undergoing a cardiac procedure recently, a surgical procedure recently, or he's in an ICU, for instance, with indwelling central lines. At this point, we will have to comply with the timing of the antibiotic administration, and we have to think about procedure length and timing of rebolusing. So this is a very complex approach.
The answer is that 38% they will use vancomycin, but 27% cefazolin and 32% ceftriaxone. So really, it's balanced.
Nice split.
Yes, 1/3, 1/3, 1/3.
And that's interesting because 1/3 thinks I can carry on the same treatment I've been giving to the patient to treat the bronchitis, because it covers nicely well the spectrum of Staphylococci and some other gram-positive species, so may sound reasonable.
Ceftriaxone plus levofloxacin.
Plus levofloxacin.
Ceftriaxone alone, very few.
Okay.
3%.
So they think I add something to the treatment I already gave, because they think, and I think this is a wise thought, I may have selected some resistances. So the cephalosporin is kind of reinforced by a different antibiotic that has synergistic effect. This I can understand. I would say that cefazolin probably here plays a little role, because what we have is a randomized study that sets the ground for a first implant. But in this study, the high-risk patient were excluded. No patient who already had antibiotic treatment, no surgery patient that had been done in the previous month, no patient who had had an infection, no patient with prostatic heart valves, or replacement patient or lead revision for dislodgement, or other lead revision or other pocket revision. So I would say in these settings we have no data to corroborate our choice, and we would think something else. Now my pathophysiologic guessing is that reasoning about the resistance to methicillin or oxacillin of Staphylococci that live in our hospitals, any treatment which is a cephalosporin or a beta-lactam would be ineffective in this patient. And we know that a hospital-acquired infection would be almost lethal for this patient, especially when we come to prosthetic heart valve patient. So I would say cefazolin, no. And while we see that our slides will be regained, I would share my guess and prophylactic choice with those who chose vancomycin.
Maybe we can have just a short break. There's a very interesting question. You were dealing with early reopening of the pocket. What do you call early reopening?
Early reopening in my practice is something that happens within 30 days from the first 30 days. I wouldn't say I wouldn't say 7 days. I would say 30, because I still think of a pocket that is under development. There is capsule formation, there is ongoing new vessels trying to repair the surgical damage. This is a highly vascularized system with a lot of permeability for bacteria that could accidentally enter a pocket to enter the circulation.
So this is a period where you are really...
It's a period where I'm really worried. After first month, I would call it delayed, although I'm uncertain about this boundary, to be honest. But I would say my early is 1 month. So while we wait to move on, this slide, I totally agree that although we have no data, I would use vancomycin for this patient. Alternatively, if the renal function were greatly depressed, or if the patient had central venous line that have been staying there for more than 2 days or for more than 24 hours, I would say, daptomycin would be my first choice agent, based on one simple consideration. Every hardware in the body that has been staying there longer than 5 to 10 minutes is colonized by biofilm, which is mainly represented by coagulase negative staphylococci. And these species are resistant to the action on any antibiotic but daptomycin and minocycline, because staph embedded into biofilm require a concentration that we will never achieve in clinical practice. It's 1,000 times higher than the therapeutic levels we are delivering. So indeed we have to move to something more, which would be daptomycin, which is quite tolerable for the patient. But this is not in the guidelines. Anyway, this points out the deficiencies that we have in our guidelines and the deficiencies that antibiotic agents have to be prophylactically active against some species of pathogens that may colonize the pocket. Whereas in the pocket we have animal data that tells us that the combination of minocycline plus rifampin is really helpful and bactericidal. So I'm opening a question to the audience, provided that I use vancomycin. Do you see a role for topical antibiotics as prolonged prophylaxis until wound healing occurs and the pocket is completely sealed to the external environment? Do you think that there is no role at all? Indeed, it should be avoided. Or there's no role because no antibiotic would be bactericidal? Or do you think that it could be recommended? Or is anyone already using antibiotic in the pocket?
So you mean this is topical, like injected
like
in
injected
the pocket
or
something like it? Okay. People are
So
voting now.
when I think of this, I want that the audience realizes that the topical antibiotic is a prolonged prophylaxis that has to cover the broad spectrum of pathogens, has to achieve a bactericidal concentration of the drug, has to stay there for the complete healing of the wound, because at that point the inside of the pocket would be completely sealed and shall not have systemic effect to the patient, because it could be toxic. So what is the feedback we have from the audience, Jean-Claude?
The feedback is that it's still balanced. 36% or 44% now, no role for topical injection, I would say. 31 recommended, does not harm and may help.
Okay.
And 14% always use it.
Fantastic.
Yes.
Means we have an attitude to provide something that stays there, but yeah?
And 20% no role should be avoided to avoid resistance.
Fantastic. So this is, we have to cover a gap in our knowledge, and I see I am not delivering this, but I will hand it over to Jay. What I'm telling people now is that there's probably a role to provide bactericidal activity sustained for 7 to 14 days until complete healing occurs and the inside is totally sealed against the external environment. We have this antibacterial envelope that is active against methicillin-resistant cocci, that's the species we are threatened about, is active against non-staph pathogens and has a high topical concentration without systemic effect for the patient. So this is the new prophylaxis we have to focus above, on top of all the other regular preventative measures.
So this is on top of prophylaxis, antibiotic prophylaxis.
Yes, I would say we have to think of it. And with this, I hand it over to Jay, that will bring us in another true clinical case.
Maybe we have time for a question.
So. Should we ask Mauro some questions after such a fantastic run-through of all the potential risks and the preventative strategy? Mauro, I was very interested in your patient who had anticoagulation indication, and I'm very interested here, what level of INR do you aim for in the low and high risk patients, and what level of INR would you consider as prohibitive for proceeding with?
Normally, we can use the EHRA recommendation, and in those patients who have a minor or equal to 5% stroke risk per year, I would aim to a 2.5 range to do my surgery, with or without aspirin added.
Yeah.
Whereas if I have a patient who is a high thromboembolic risk, greater than 5%, I would aim to a 2.5 to 3 INR range. I would consider strongly prohibitive a patient who already has a TIA despite being in warfarin regimen, and where I think I should probably add aspirin to high-dose warfarin. That could be a really challenging situation. I normally try to lower that below an INR 3 and keep on aspirin, and in that cases I normally try to avoid hematoma formation by placing a pocket drain for 24 to up to 72 hours.
Okay. Do you ever use prophylactic pressure dressings or anything like that?
We have small experience about that, and as I've grown up as a so-called young surgeon in my early youth, I've been always resorting to the pocket drain, because it's an old British surgeon saying "in doubt, drain."
Excellent. Okay, well, we might come to some old English surgeons later on then.
Okay, so maybe we move on to the presentation of Jay about this topic of prophylaxis.
Well, thank you, Mauro. You've talked in great depth about the primary implant and all the patient-related factors, the device-related factors, and the procedure-related factors, and the surgeon-related factors. So I'm now going to run you through a real-life case. One of my patients who I've known for a very long time, as you will see from this very long list of his procedures. He was born in 1960, so he's currently 57 years old, and I've known him for over a decade. He has phenotypic hypertrophic cardiomyopathy with a 16 gene panel that was uninformative. And in 2006 and 2008, he underwent alcohol septal ablations for very symptomatic LVOT obstruction. Following the second of these, 3 days later, he developed symptomatic complete heart block and was admitted to his local district general hospital, not the hospital where he'd had his alcohol septal ablation, in complete heart block, and was implanted with a dual chamber pacemaker. In clinic review 2 years later, he had some non-sustained VT on his pacemaker interrogation. His LVOT gradient had returned to 99 millimeters mercury. His septum had re-expanded to 2.4 centimetres, and there was an unusual episode that his uncle died of sudden cardiac death, age 40, though hadn't been diagnosed with hypertrophic cardiomyopathy. And it was felt, in view of that risk profile, he should be upgraded to a dual-chamber ICD, which he duly was 2 years after the implantation of his pacemaker, with removal to prevent redundancy of his pacing lead, his RV pacing lead. And he did quite well for a period of about 5 years. He had some paroxysmal AF and required a beta blocker and a NOAC, but his LV function was normal, although his left atrium was slightly dilated, in keeping with his paroxysmal atrial fibrillation. Unfortunately, a year later, he'd developed the dilational phase of hypertrophic cardiomyopathy. He'd got persistent atrial fibrillation, overt symptomatic heart failure, NYHA 2 to 3, with an LV that was now severely impaired, and also biochemical abnormalities with gout, and just to complicate matters, obstructive sleep apnea. So in October 2016, 8 years after his original pacemaker, 6 years after his initial ICD upgrade, he was upgraded to a CRTD. Unfortunately, he responded brilliantly. The procedure was technically very challenging, lots of fibrosis within the pocket, and an anterolateral vein was the only one that could be selected in the CS. Unfortunately, that caused phrenic nerve stimulation, which was quite surprising, and resulted in him having a very severe clinical twitch. But he felt vastly better with his CRTD in situ. He had some positive remodelling of his ventricle, and we were very reluctant to re-enter his pocket in the early phase. And he persisted for over 3 months and actually went on holiday and felt much better, but finally decided he couldn't cope with the twitch, and we had to reposition his LV lead. He didn't feel as good, even though we actually got the lead into a posterolateral vein, which we thought would be better. We had no twitch at all, but he didn't feel as good, and we had some problems with atrial fibrillation rate control. So then he went on to have an AV nodal ablation, 2 days after which he was admitted hospital unconscious with an acute subdural hematoma. This necessitated neurosurgical intervention, and during his prolonged recovery from this, he developed strep gordoni endocarditis, proven on TOE to be affecting both his mitral valve but also his aortic valve. So he had a very difficult situation of a patient who couldn't be anticoagulated, who had multiple valve endocarditis with a CRTD in situ, And the only way of managing that for us cardiologically was a sternotomy, extraction of his pacing system, and AVR and MVR. But we had to negotiate with the neurosurgical team about the length of time that he needed to recover from his subdural hematoma before we could anticoagulate him to go on bypass for the procedure. So that ended in a very prolonged admission, huge expense, huge morbidity for the patient, who has fortunately survived all of this. He's lost 6 stone in weight during his 3-month admission. So what I want to now challenge our audience to do is, from all the information that Mauro's provided to them, we're going to try and work out what the risk at each stage of these multiple procedures our patient provided. So his de novo pacemaker implant in 2008 we're going to try and define the risk of infection. We're going to use the audience to do that. We're going to discuss the technique and prophylaxis that was utilised and the outcome of that. Now, just as a little filler for the audience before we start, Mauro's presented some great data from some meta-analyses, but I want to try and use one study that's really provided some in-depth analysis, and this is the data from Ricky Kirkfeldt et al. In Denmark, who looked at the average risk of infection for a new implant, which was 0.6% with a significant range, 1.5% for a box change, and 1.9% for an upgrade, bearing in mind that we're going to consider all of these in this patient potentially. More importantly, they looked at particular factors that affected the risk for an individual patient, so that range around 0.6, 1.5 and 1.9. And there were factors including the sex of the patient, with female patients having a higher risk, the age of the patients, with younger patients having a higher risk, the body mass index, with slender patients having a very high risk, but really importantly, centre volume, the highest risk in centres under 250 procedures, with the lowest risk in centres over 750 procedures per year. The operators, similarly, in operators with a annual volume of less than 50 cases, the twofold increase in risk compared to those doing more than 150. We've talked about the difference between single, dual and triple chamber devices, and we'll come back to that in more detail. And so I think we're starting to gain an idea of the potential risk profile on
this is
patient.
Operator and not center,
The
activity.
Operator, less than 50, centre less than 250 being the main risk factors. And of course, it's very important to consider not just centre and operator risk, but individual patient comorbidities. And we know that on the systematic reviews, there were a number of really important risk factors. The single most important risk factor was the absence of antibiotics. And I'm delighted to come back to the question that Mauro asked, and the audience overwhelmingly felt that antibiotics were, in an individual tailorized manner, the most important factor. So very, very important that our audience are already aware of that. And these are all the multiple risk factors that we've got to consider that Mauro's kindly been through in some detail. So for our patient, having his de novo dual chamber pacemaker implant after his alcohol septal ablation, do the audience think the risk of infection for this procedure would be less than 0.5%, 0.5 to 1%, or more than 1%? And bearing in mind that you have to consent your patient up front and provide this as a medico-legal requirement, it'd be very interesting to see what people feel the risk factors for that are. Whilst we're waiting for the audience to vote, of course, we'll move on and talk about what happened in that case. Because it was a dual chamber pacemaker. We know that single chamber pacemakers have less risk but wouldn't be as appropriate in a young patient with complete heart block. He had relatively little comorbidity in terms of risk factors for infection. The centre in which it was implanted was a low volume centre, less than 250 implants per year, although the operator was one of the 2 implanters there doing between 50 and 99 implants per year. It was implanted in a cath lab rather than a theatre, and within the British Heart Rhythm Society guidelines, we are recommended to use theatre or theatre quality air changes within a catheter lab. He had a single dose of IV cefuroxime, 1.5 grams at the start of the procedure, chlorhexidine skin prep, and the outcome, as we know, was that there was no infection. So I'd be interested to see, Jean-Claude, what the audience felt his risk was.
Well, the majority, but this is a short majority, this is 52%, feel that it's more than 1%.
Right.
And then we have 33% between 0.5 and 1, and then we have 40% less than 0.5%.
So it was either very low or less than 0.5 or above 1. And I don't think we can really say we know the answer in every individual patient, but we know the average is 0.6. We know this patient had a number of risk factors in that it was a low volume centre, although a reasonably high volume operator. He had little comorbidity. And I think it brings us to several points that are really highlighted from Mauro's talk. First of all, that de novo implants, it's very important that less is more, but that in terms of the operator and the centre, more is more. And of course, we should always use an antibiotic. And in primary prevention, this is slightly different to when you're coming to in a de novo implant to a secondary procedure or an upgrade. And I've chosen to use, for my point of discussion, the joint British Society guidelines, which drew heavily on microbiology input. And as Mauro kindly showed us earlier, we're dealing mostly with infections due to coagulase negative staphylococci or Staphylococcus aureus, sometimes methicillin resistance, and then a small number of enterococcal, streptococcal, and gram-negative bacilli infections. And the guidelines within the UK are that we should use a single IV bolus before surgery, that we should not be using in-pocket antibiotics, there's no evidence, that we should not be using prolonged courses of oral antibiotics because there's no evidence, and that the drug of choice should be a glycopeptide such as ticaplanin. But of course many centres, and we saw from the audience question earlier, using cefuroxime in a low risk de novo implant. But I think the important thing is that we don't add antibiotics into the pocket and we don't use prolonged oral courses. So this poor gentleman, having had a dual chamber pacemaker in 2008, in 2010 was felt in the outpatients department to have significant risk to require an upgrade to an ICD. And we may return to this later on when we see subsequently what happens to him. And in this case, it's an upgrade. It's not a box change, it's an upgrade. So we have to define the risk of infection. We have to consider our technique and prophylaxis, which may be very different to the implant of his pacemaker. And we have to look at the outcome. Now, we've seen from large meta-analyses and from individual large-scale studies that any generator replacement or upgrade has an increased risk of infection. And when we look at box changes in particular, the overall rate of complications is less than a de novo implant. Risk of death, stroke, lead complications, very rare. And all the complications are related to infection, up to 5% in some studies, on average about an odds ratio of 1.7. So significant increase in risk. And the Kirkfeld data again drilled down into this in enormous detail, comparing single chamber pacemakers, dual chamber pacemakers, CRTP, single chamber ICDs, dual chamber ICDs, and CRT. And as we can see for this patient, the overall complication risk for an upgrade to a dual chamber ICD was in the region of 22%. Now that's not just infection, that's the overall complication rate, but infection will be a significant part of that.
Yes.
So bearing in mind all of those factors, I'd like to ask the audience whether they feel the risk of the upgrade to a dual chamber ICD has an infection risk of less than 1%, 1 to 2%, or above 2%. And whilst they're deciding, we'll talk about what actually happened to this individual. He did have a dual chamber ICD upgraded from his dual chamber pacemaker. We extracted the redundant RV pacing lead, which might be a completely different debate on a different day, but we may take questions on that later. He still had little comorbidity. It was done in a large volume centre with more than 1,000 implants per year, a large volume operator doing more than 250 implants. The operator is surgically trained and sits on the faculty of the Royal College of Surgeons technical course, which is mandatory for all cardiologists in training in the UK. For a registrar to gain accreditation in pacemaker implantation, they have to do, it's only a one-day course, but it teaches really important skills, as we'll discuss in a minute. The patient had pre-op MRSA screening, which would obviously direct antibiotic choice if there was MRSA positive cultures. It was a theatre implantation because of the extraction with IV cefuroxime and gentamicin. Again, this theory that dual antibiotic prophylaxis may provide a better outcome. chlorhexidine, skin prep, and of course we know there was no infection. So, Jean-Claude, what did the audience think the risk was?
The audience thinks that the risk is quite high, more than 2% for 60% of our audience. 33%, 1/3, they keep it between 1 and 2,
Okay.
and very few less than 1.
And I think I'd agree with the majority of the
Yes,
audience.
yes.
I think the risk at 2% is probably quite conservative and may even be higher. This was only a second procedure, though, in a young individual in a very high volume centre, with every effort being made to minimise the risk. So I think above 2% is still a good estimation. And so it comes to the points that we may discuss later, that upgrade procedures really are the greatest risk to our patients in terms of infection. Surgical technique is vital, and I'm going to expand upon that in a minute. And dual antibiotic cover in individually selected patients often may have a greater antibacterial spectrum. Now, the cardiological surgical course that I mentioned earlier that's run at the Royal College of Surgeons teaches really basic surgical skills. Really basic as in, what are Langer's lines? These are lines that the skin folds take when moving, and that we should never cut across these. And of course, most of us implant devices with a line, an incision line, that crosses 4 of these. So you're creating tension across, perpendicular to the line of the incision. Surgeons teach that wounds should never be made with blunt dissection using scissors in reverse, that they should be clear tissue retractors and cutting with scissors. They teach that we should not use silk, which was a massive shock to me when I first went down a few years ago. Braided sutures increase the risk of infection. They harbour not only bacteria but thrombus within them and increase the risk. So we now tend to use Ticron. So there are a number of really basic surgical skills that were very important. Which brings us now to this poor gentleman's next procedure, which was his third procedure, his upgrade to CRTD, having deteriorated significantly clinically with heart failure. So we've got to try and define his risk, and this is a third procedure at the same site. We know that CRTD upgrade from the Kirkfeld data has at least a 20% complication rate, much of which will be infection. He had new potential risk factors, that he was in persistent atrial fibrillation with anticoagulation, he had a low ejection fraction, and biochemical disturbance with gout and obstructive sleep apnea. So again, to the audience, in this case, they think the risk of this third procedure for infection is less than 2%, 2 to 5%, or above 5%. Because what actually happened in this case was that, again, he's only 56 at this stage, but has some comorbidity. It was in the same large volume centre, but with a different high volume operator, with pre-op MRSA screening that was negative, theatre implantation, dual antibiotics, chlorhexidine skin prep, and diathermy being used, because there was a huge amount of fibrosis within the pocket at this third procedure.
What do you mean by diathermy? You mean...
Now, there are various terms of diathermy. In this case, it was bipolar diathermy, as in a high temperature device to try and reduce the risk of bleeding. But of course, this is slightly different to the plasma blade, which is now available, which uses water lysis, which doesn't put the leads at risk. And at this time,
this was one of the questions of the audience.
Right, so diathermy is a hot knife, essentially, to reduce bleeding.
Okay.
It is not the plasma blade, which is currently a separate option that has a much lower risk of lead damage. So there is some risk of lead damage from diathermy, although it's said not to be. I still think there is a risk, but it was because of the amount of fibrosis in this case. And interestingly, the outcome was that there was no infection, but as we'll come to see in a minute, when we did the fourth procedure, the unfortunate reposition, there may have been infection acquired at this time. So what did the audience, Jean-Claude, think the risk were?
Well, 2/3 of our audience are very pessimistic. They think it's more than 5% the risk of infection, and 1/3 between 2 and 5%. So I think really people are aware of the risks.
And I think I would completely agree with that.
Yes.
And certainly 5% at least. And that's a difficult thing to consent patients for, but we have to be very open and honest. And these were the things that I felt were worthy of discussion. They're very high risk of a CRT upgrade. Should we have used Tyrex at this point? This was a third procedure. Within a few years, Tyrex was becoming available, and we'll talk about the evidence in a minute. And should post-op oral antibiotics have been used, we've heard from both from Mauro and from the British Society guidelines that there is no evidence. Tyrex, we've heard as earlier, provides minocycline and rifampicin in a biodegradable pouch, which is released over 7 to 14 days, an absolute minimum of 7, but up to 9 weeks, in fact, in some cases. And interestingly, the pouch, I've used a number of these as part of the RAPID study. You're supposed to put the leads and generator within the pouch. I found it extremely difficult to get the leads into the pouch, particularly with CRTD implants. But so there is a change in surgical technique required, that the pocket needs to be a bit bigger, and that can be very difficult if you're doing a box change or an upgrade. And of course, we've seen from single centre studies comparing the envelope era, the Tyrex era, with the pre-envelope era, that there has been a statistically significant reduction in infection. But this is, of course, retrospective analysis, is not randomised controlled trials. We've even seen now a meta-analysis of all the single centre studies showing an overall benefit of Tyrex in box changes. But what we really need to know is the results of the RAPID study. And the RAPID study is a huge Medtronic-sponsored 7,000 patient study with one-to-one randomisation, 3,500 patients in each arm at box change or CRTD implant. There were a few CRTPs early on, but mostly CRTDs. And they're looking at the primary endpoint of infection at 1 year, but also at lead function in the longer term, because is putting something else into the pocket, coiling the leads in a different way, going to affect lead function? We don't know. This will be a really important study that's going to guide our clinical practice in the future.
So no result.
No results as yet.
Just
they have stopped recruiting. The data is being analysed at the moment. I have a sneaking suspicion HRS next year might be a very interesting place to be with RAPID study. Now, of course, this poor man, we tried to avoid like mad repositioning his lead, but ultimately we had to reposition his lead. He couldn't cope with the twitch. Fortunately, we left it at least 3 months, Mauro, and of course you said that early re-intervention on LV leads was the main cause of problems, and in this case we were fortunately able to wait a little bit longer. But his risks were really probably quite significant at this point, and because when we opened the pocket we found a biofilm, some slough, we sent a culture for this, and we'll wait and see if that was infected. So, in terms of this procedure, we did things pretty much the same, but we didn't know if the device was already infected, because as soon as we opened up, we found the biofilm. We hadn't consented him for extraction, we hadn't prepared for extraction, but we know about a third of these cases with a biofilm will have coagulase negative colonisation. It was our high-volume centre with a high-volume operator, and we'd done all the pre-op screening we could. We'd used 2 antibiotics. We did use a Tyrex pouch because we felt with biofilm there that this was an indication, even though we'd only been previously using it in the study at that time. We also gave oral antibiotics for 2 weeks afterwards in the full knowledge that it didn't make any difference, but we felt there was a really high risk of infection. And of course, the outcome was that he went on to develop a subdural hematoma after his AV nodal ablation, and unfortunately this was an infected system.
Just one question regarding MRSA screening. Do you perform it in all patients?
Every patient coming to our hospital for a routine procedure comes 10 days before and has swabs from the nose, ear, groin, axilla and throat. If we find MRSA, we change our prophylaxis not to use gentamicin but to use vancomycin, and they're treated much more aggressively. They also go to the end of the list, which isn't part of there's no evidence for it, but it's part of guidelines. They should be done on the end of the list, so we change what we do. It also gives us a chance to fully assess the patient, discuss their risks, talk about what anticoagulants they're on, because I've had patients who've stopped their aspirin and clopidogrel but have carried on with their Plavix for some reason, which of course is the trade name for clopidogrel, and then they've had bleeding complications. Having sworn blind they'd stopped all the tablets. So it's a very important part of the process in our hospital. Now, of course, once we'd come onto an infected system, we had an awful lot of work to do. This was a really massive infection in this patient, and we know that we need to take the device out, but we couldn't take the device out in this patient. Even though it was infected, even though he had endocarditis, he'd had a subdural hematoma. We had to wait 6 weeks, which was a good length of time, and when we need at least 6 weeks, but usually 6 weeks after the hardware comes out. Obviously, if you're going to leave hardware in because the risk of extraction is much higher, you need 4 weeks, and if you can just take a simple infected system out that hasn't got endocarditis, you only need 2 weeks of antibiotics. Of course, often we're initially treating blindly when we don't know what the bug is, and we tend to use flucloxacillin as first line for an inflammatory treatment, unless they're resistant, in which case doxycycline, linezolid or clindamycin could be used. Or if there's a pocket infection from a box change, we would go straight in with vancomycin. And if there's endocarditis, blind vancomycin, meropenem, sometimes ticaplanin are often first-line agents. But of course, once you know which bug you're dealing with, you go by the sensitivities and resistance run by the microbiology labs. And the really important thing is this, that these patients need MDT management. If I'm dealing with an endocarditis patient, I like the microbiologist to be holding my hand, advising on the antibiotic choice, advising on the dose, and using local knowledge of resistance to direct things. So we tend to be guideline driven, but we're very worried about resistance developing, and therefore the push towards ticaplanin we haven't really adopted in many of our primary prevention patients. And of course, this poor gentleman was in hospital for 3 months prior to his extraction, and we ended up implanting him with an epicardial pacing system because he'd never had any therapy from his ICD. We felt that his mortality risk was maybe not to survive a full year, and therefore we've just left him paced with epicardial leads on the LV to try and give us multiple options to improve his LV function again. And of course, we're now worried that epicardial leads, 10% failure rate at 1 year, so we've put 2 LV leads on and attached it to a biventricular pacemaker. Thank you very much. I'm now open to discussion.
Thank you very much. It was really a very, very interesting case. There are many questions. One of the questions was about the plasma blade. So you told that you don't use it in every case.
No, I think there are some potential advantages. I think having used it in a few cases, it's a great tool. You need a little bit of experience with it, learning what level, because that you have a completely separate piece of equipment that drives the level at which you're using it at. So I've taken advice from Medtronic, who've actually come in and done a number of box changes with me. It gives a phenomenal ability to free up leads when you're doing upgrades without causing any damage to the lead, because it works on lysis of water rather than heat from diathermy. So I am starting to use it in cases where I open up and there's a huge amount of fibrosis around the leads. I like to have the plasma blade on my shelf in my armoury, but I'm not using it routinely because my hospital finance director won't let me use it for every case.
Yeah, I can't believe it.
One person is asking what about the use of shell pockets? But this is exactly what we were discussing today.
Yeah, and I think that we don't know yet the results of RAPID. It's going to be really important. But of course, RAPID looks at box changes and it looks at CRTD implants. This gentleman had an upgrade to a CRTD from a dual chamber ICD, having previously had a dual chamber pacemaker. So the third procedures will be a subgroup analysis, hopefully, of the RAPID study. But those are the sort of patients. CRTD upgrades, we know that they have a 25% complication risk. We know that's at least a 5 and up to a 20% infection risk. It's an expensive device that we're putting into a patient that when we extract it for infection, we drop it in the bin and wave goodbye to a very large number of pounds and euros. Please still talk in euros at the moment.
But apart from the pounds, apart from the euros...
Very important, yes.
Yes, it's very important. But don't you think that really the mortality rate of these patients with infections is so high, but we are in duty to provide them with the better preventive measures, including the SOX. Do you agree, Mauro?
Totally agree. Indeed, after the best treatment we can give to an infected patient, mortality will be anyway 20% by the end of the year and 30% for those who have endocarditis. So definitely, if you look at this, it's a drama that we should avoid as possible.
Whatever the cost.
Yeah,
whatever the cost.
What is the cost? And indeed, treating this patient is much more expensive than providing an envelope to all those who we are today replacing or candidating to a CRTD device.
I couldn't agree more.
So actually it's value-based medicine, it's not cost-driven medicine that we are talking about.
Well, unfortunately we are really approaching the end of the webinar. I would like to close this session by reminding some key messages of our daily practice, for our daily practice. First of all, we really learned that there are patients who are at higher risk. Maybe patients with with the longer procedures, with the more complex procedures. First of all, we also learned that you, in your daily practice, you're really trying to provide them with the best, with a tailored approach in order to prevent these infections. And this tailored approach includes tailored prophylaxis, includes the use of Tyrix in selected cases, the use of very specific surgical techniques when needed. So really what we have learned today, what we have reminded today, is that we are really all concerned about this very important risk, lethal risk sometimes, of infection in our patients. So preventive measures should be known. We should implement them in our daily practice. Regarding the Tyrix, because it's important to remind it is still under investigation, but still the results are promising. I mean, we have a lot of observational studies, and it's interesting to probably to use this device when indicated, when the patient has a high risk. So thank you, Dr. Mauro Biffi. Thank you, Dr. Jay Wright, for this very, very interesting webinar. Thanks also to Medtronic, who supported this webinar with an educational grant, and we hope you enjoyed this. There were a lot of questions. I think in the next days we will be able to answer some of these questions. So it was really a pleasure to share it with you and with the audience. Thank you very much.
Thank you so much.